Good afternoon, everybody. My name is Maria Restrepo Toro, and I am the co-director of the New England Mental Health TTC. Before we start our session today on using data for equity, we really want to acknowledge how deeply disturbed and sad we all feel today. Our hearts and prayers are there with the elementary school in Texas. Little angels have been taken away from us. And then in addition, this is only a week before the tragedy that happens in Buffalo at the supermarket. So here we are talking about racial equity and advancing cultural humility. This is just devastating, and we really appreciate you joining us today. We understand that it's very sad, and we're all here together, and want just to please take a big breath, a moment of silence, and we will get going with our session. And we thank you very much that you're here with us today. I'm now going to turn it to my colleague, Dr. Janan Wyatt. She's an associate research scientist at the Yale School of Medicine, Department of Psychiatry, at the Program for Recovery and Community Health. She will be leading the session, presenting the speakers for today. Thank you very much.
Thank you, Maria. Good afternoon and welcome, everyone. We're very excited that you can be here this afternoon sharing this space with us. Just to piggyback off of Maria's words, I encourage you all to really take care of yourselves during this time. That's pivotal, especially given the work that we're engaged in that kind of coming up against a lot of the recent events. So I just wanted to add that tidbit that self-care and community care is really pertinent at this time. Again, my name is Dr. Janan Wyatt. I'm an associate research scientist with the Yale School of Medicine, and welcome to our Racial Equity and Advancing Cultural Humility for Organizational Change learning session. The focus of our session today is using data for equity, which is really, really important. So I'm excited. The speakers will be here sharing their brilliance with us. At this time, I'll go over a few housekeeping items. The first being microphones will be muted during today's session. At designated times, such as during the Q&A, you can use the raise your hand feature to request an open mic. When speaking, we really ask that you try your best to eliminate any background noise so that we can hear you clearly. Other ways to engage with us during the presentation and Q&A is to submit questions or comments throughout the presentation using the chat function. Also, we are pleased to offer the option of closed captioning during this webinar. You can select this option, and change the transcription settings by clicking the CC Live transcript button at the bottom of your Zoom screen. We also want to remind you that registration affirms your consent to receive an evaluation follow-up link via email at the end of our session today. Registration also confirms that you consent to the recording of this session. If you experience any type of technical difficulties, please let us know via the chat function and we will be sure to help you. At this time, I also want to announce we have a disclaimer. Our funding comes from SAMHSA, the Substance Abuse and Mental Health Service Administration. The views and opinions expressed in today's session from the presenters as well as the moderators are the opinions of them and not SAMHSA. Also, before we turn it over to introduce our speakers, we just have some comments about language. The Mental Health Technology Transfer Center Network uses person-centered, affirming, and respectful recovery-oriented language in all of our activities. During this session this afternoon, please ensure that whenever you are contributing to the conversation, engaging with us, and sharing space with us, that you also use language that is affirming, respectful, and strengths-based. Today's session will be led by the trainers from Third Sector Capital Partners Incorporated, a nonprofit firm that collaborates with organizations to ensure they have the systems, tools, and data to work with and improve the lives of people that they serve. At this time, it is my pleasure to turn the mic over to Taylor Bryan Turner, who is the Regional Administrator of the SAMHSA Region 1 office, who will share more about the speakers this afternoon, as well as their equity-centered approaches and the work that they are conducting in the New England region. Taylor, the mic is yours.
Thank you so much, Dr. Wyatt, and good afternoon, everyone, and Maria for your sympathy and empathy this afternoon. Thank you for the strength to get out of the bed and persevere today after the horrific attacks in our country over the last several days. Our MHTTCs across the country work tirelessly to ensure we are trauma-informed, culturally appropriate, and that our well-being is protected. And I thank you for your dedication to community each day. Thank you, Ingrid, for your dedication and vision for this initiative. So the New England MHTTC's REACH series presents the opportunity to consider ways to develop and put into practice an action plan to shift policies and practices to ensure cultural responsiveness and workplace equity. Using data to drive decision-making is critical to ensuring that behavioral health services improve the lives of all people, no matter their race, background, or circumstance. I'm actually here at a conference with the National Judicial Task Force to examine state courts' responses to mental illness and collaborate on the decriminalization on people who suffer from mental illness. And we know the racial implications among those incarcerated in general are disproportionate. So our work is all aligned. A key SAMHSA strategy is to identify innovative practices in behavioral health that advance recovery on the ground and in community. When I met the members of Third Sector team and learned of their work around the use of data for meaningful equity-based solutions and results, I knew that I wanted to extend them the opportunity to work with our New England Mental Health Technology Transfer Center's REACH community. We have all been through great transitions, but Third Sector's commitment to treatment, recovery, and mental health supports have been appreciated and expanded in different parts of the country, and aligns well with SAMHSA's principal goals of social and racial equity, workforce recovery, and data-driven evidence-based practices. So today it is my pleasure to introduce you to Maria Posey, Third Sector's Managing Director, and Emma Goodman, Manager. I now turn the session over to you both, and I'm so happy to see this day finally come to fruition. Thank you so much for all you do.
Welcome, everybody. So I am also a Maria. That's going to be nice to keep track of. Got a namesake here at the MHTTC. We are so excited to be talking with you here today on some practical tools and techniques for how programs to advance mental and behavioral health can use data for equity by aligning systems, processes, and tools for improved decision-making, and ultimately services better equipped to meet the needs of different people in need of mental and behavioral health services. So let's move into the presentation for today. This is just a quick overview. We're going to welcome you all, and again, encourage you to drop your name, your organization, and a quick reflection on what equity means to you into the chat. This will be a chance to practice the interactive nature of our presentation, which we will be using throughout. So we'll be, first of all, giving an overview of who we are and what brought us here to you today. Over to my good colleague, Emma Goodman, who is a leader in our mental and behavioral health practice and has worked primarily on the West Coast in a number of our mental and behavioral health programs. This will be a chance for you to really dig into some of the tools and techniques we'll be sharing, and then we'll close out this session with some next steps and questions. So here we are again. I'm Maria Posey. I'm a managing director based in the DC area, and I oversee Third Sector's federal portfolio of work. So that means I interact with a number of different federal agencies cross-sectorally, which includes Health and Human Services, SAMHSA, as well as the Department of Labor, Department of Justice, Department of Agriculture, to cover a variety of workforce development, early care and education, diversion and reentry projects and initiatives that Third Sector leads around the country. And then I'm joined today, as I mentioned, by Emma Goodman, one of our project managers, a rock star project manager who champions a lot of our equity-centered work in mental and behavioral health supports. Right. So for today, we hope that you will all have a chance to gain a better understanding of how to practically use data to fully realize and operationalize equity goals. And we will be showing you a 5-step framework, a process, if you may, for how to do this. We'll be walking you through each of the components in this 5-step framework, giving you examples of how it's been applied, but most importantly, giving you a chance to practice and apply this in your own work, in your own context. We recognize it will not be a complete exercise, and this will just be a flavor, an initial taste, with the hope that further discussion can be had either at the diversity talk that we will be facilitating on June 14th, or in one-on-one follow-up conversations. You will get a chance to see practically how some of your peers in primarily the West Coast have applied these different steps, and then work tangibly to think about the applicability in your own settings. We will be monitoring questions in the chat and may have an opportunity to get to a few today. But more importantly, we will be doing a diversity talk on June 14, which will not be so very structured and really a chance to dig in to some specific clarification questions, or just a brainstorm on how some of the pieces today may be used in your own contexts. So we strongly encourage you to add your questions, to note your questions, and also add them in a follow-up survey so that we can make that diversity talk fully tailored to the group's questions and requests. So now we just want to share a little bit about who we are, recognizing that we are probably a new entity to most of you, and how our focus in mental behavior health really has been more on the West Coast. As was mentioned up front, we are a national nonprofit technical assistance organization that works with our government agencies towards reorienting services in ways that tangibly improve outcomes and equity for all people, irrespective of their race, background, or circumstance. We work directly with service programs, and over the past decade have helped our government partners and their community partners reorient over $1 billion in program services towards equity goals using the tools that we will be walking through with you today. And you'll note we've been all over the country, including in New England. So we do have a very active presence and are actually headquartered in Massachusetts, even though most of our work in Massachusetts has focused more in the early education and workforce development areas. We've also worked in Connecticut and Rhode Island and New York. All right. A key aspect of our work is people. Even though we work with systems and processes, the person receiving, participating, benefiting from a publicly funded service is at the forefront of our mind always. And in a mental and behavioral health setting, that means that we look at the entire journey that a person experiencing mental health needs goes through, from pre-referral into services, through the structured referral process, intake and enrollment, what service delivery looks like, and then many times what graduation looks like. And our work on the West Coast has focused primarily on people with serious mental illness. And so graduation often means graduating to lower levels of care opening up spots for others who may be in greater need of those assertive community treatment, intensive care approaches. And you'll see at the bottom here some of the various different ways that we engage with our government partners and community partners on examining some of the service elements at each of these steps on a journey. Everything from how do we reach priority populations into a referral structure? What is the timeline between a referral and an intake system, knowing that access to expedient care is a critical factor in ensuring that an individual gets what they need in a timely manner? What are the eligibility criteria that need to be in place in order to ensure equitable enrollment and intentional enrollment of people who a lot of times may have been historically underserved due to race, background, circumstance? And then what does a service model actually need to look like in order to achieve intended impact? What are the evidence-based practices out there for different treatment models proven to be effective for different people? Knowing that one size doesn't always fit all, and also working across urban and rural settings, resources may not be equally available. So how might one tailor an evidence-based practice in a smaller setting, for example, when all of the resources may not be on hand? And how does one even define, that's what we're going to get into today, what service success looks like? There are lots of different outcomes to choose from, and we will be getting into that today of how do you even decide and prioritize what success actually looks like, and then make that a commonly understood measure. Let's look at some examples of projects that we've had along these journeys. So today we're going to be talking a lot about the data side that guides the final service adjustments to be made. But as you can see, we have worked at each stage of the journey. For example, in King County, Washington, we helped streamline the referral and intake process, cutting down the time between initial contact and intake by over 70%. We helped create new eligibility criteria in California to really prioritize and define what it means to be of highest need, recognizing that that was not uniformly understood between providers in a single county. We have helped define step-down criteria to really be clear about readiness for lower levels of care, understanding that there's going to be infinite amounts of need for higher care, intensive care treatment models. And there is a time when people experiencing mental illness are ready for lower levels of care. So being clear about that. And we do all of this work by looking at 6 building blocks of a outcomes-focused government system. So today we're really going to be digging into the data and how data is the first step in understanding what is even happening. What's going on with who is receiving services, what's happening in those services, what does success of those services look like? And only once we have a complete data picture can we start to take concrete action to reorient how services are delivered, who accesses them. And that's why services is in the front and center here, because all of the other building blocks really are in service of making the services optimal for intended impact. And the different tools then that government agencies and partners have at their disposal involve these other building blocks. So one involves the funding that government agencies use in their relationships with providers, and how are those funding contracts structured to incentivize equity and outcomes. And that can be really transformative. In some of our projects, and Emma will share, it involved setting aside a certain % of funding for the achievement of specific equity and outcome goals, thereby really putting your money where your mouth is, and letting those financial incentives really speak towards change, behavior changes in the way that those services were oriented. It also means strengthening the relationships and building trust between government agencies, providers, and community partners. We have had a chance to consult with over 100 different users of mental and behavioral health services, as well as frontline staff, clinical staff, other community partners serving the same populations, to understand what are their needs and how can they support the overall journey of a person in need of mental behavioral health service. There's also a policy landscape that a lot of times will put restrictions on funding and services. And so a lot of times we dig into the policy aspects of who really is eligible and is the policy aligned with equity goals and in service of equity goals. And then an undercurrent in all of our work is the internal culture behind the organizations. Is there a shared sense of commitment to equity? Is there a true understanding and cultural humility on what it really means to examine your own personal individual role in a service-oriented work, where cross-racial, different socioeconomic, different levels of barriers and challenges come into play, and how can that culture intentionally be reoriented to be human-centered with a focus on cultural humility? So these are the different tools that and building blocks that we focus on in our technical assistance work. And this is where we sit. So we are not clinical experts, although we pretty much always partner with groups that are, including University of California, LA's School of Medicine for a lot of our work in Southern California. We work with community partners and really serve in that middle space of facilitation, of coordination, of project and process management, really helping to drive an overall system change process. So for our government agencies that have made a commitment to equity, have made a commitment to outcomes, we really can be the partners in driving that process from start to finish, to keep all the trains moving, keep all the voices at the table, and keeping the eye on the prize. So with that concludes our overview, and I'm going to pass it over to Emma to lead us for the bulk of the session. This is going to be the most of what we do talking, and we're quickly going to be engaging you as well into this participatory session. So take it away, Emma.
Great, thank you so much, Maria. So before we introduce the 5-step data for equity process, we just wanted to take a quick pulse on how all of you feel about using data to guide decision-making and advance equity in your work. We recognize that people may be coming from different places. Some of you may feel frustrated or confused with data. Others may feel energized or really clear. So please take a minute and drop into the chat one word that describes how you feel about using data for decision-making and to advance equity in your current work. I'm seeing a must, hopeful, important, cautious, critical, insightful, complicated. These are great words. Feel free to keep dropping them in. So I'm seeing that folks are feeling that using data for equity is essential, but can be complex. And I think that this is really key and is something that we'll be talking about today through examples in California and as we go through each step in the process. So our hope today is that this session can help folks start to move from feeling cautious to a space of feeling empowered. All right. Well, why don't we dive in? Feel free to keep dropping words into the chat and looking at folks' responses. But now I will introduce a process of using data to uncover insights, design solutions, and take actions that ultimately improve outcomes and advance equity. And as you can see on the right of the slide, this process has 5 steps. And today for each step, we'll be giving you an opportunity to practice applying content to your own work. And we'll follow that by sharing examples from behavioral health systems in both rural and urban geographies that we've worked with on the West Coast. As you can see from the yellow arrows here in the process, this is a really iterative and ongoing process. So this is not evaluation at the end of implementation. Rather, we like to call this evaluation in motion. And this is really to be able to assess outcomes in real time and make updates to services that feel more flexible and proactive, as Maria was saying. On the left side of the slide, you'll also see 4 values and mindsets that we've seen provide a foundation for successful implementation of this process and of some of the individual steps in the process. And I'll just quickly walk through what those 4 values and mindsets actually mean, because I know folks have different understanding of some of these terms. The first is learning mindset, which tells us that failure isn't a bad thing. Instead, it's an opportunity to uncover new insights, let those insights lead to changes in systems and services that will then ultimately lead to better outcomes. The second is racial equity. We know that behavioral health programs, many of your programs are likely serving individuals and families from different racial and ethnic backgrounds. And looking at disparities in outcomes that result from programs really ensures that everybody is getting the support that they need in order to make movements on their recovery and stability journeys, regardless of race, background, or circumstance. The third is trust and shared accountability. We also know that when you're looking at disparities, when you're looking at your data with partners, that can sometimes feel challenging, especially if you're seeing something in your data that you didn't expect or that you didn't hope to see in your data. So building trust provides really critical groundwork for some of these collaborative conversations on data and disparities. And it's especially important for those in positions of power to prioritize doing this. And this will really help create a space where everyone involved in the work feels accountable to uncovering insights and addressing challenges together. The last value on here is being human-centered, and this means keeping end users at the center of any revisions you're making to systems and services in order to then increase the likelihood that changes feel relevant and valuable. And end users could mean lots of different things. They could be people using behavioral health services, they could be government staff, they could be clinicians or case managers. Regardless of who your end users are, staying human-centered will allow them to be able to really see their experiences and needs reflected in any changes you're making. So as I walk through the process today, I will be sure to highlight in the examples from behavioral health systems across the West Coast how both behavioral health agencies and their providers worked together to try and embody these values and mindsets as they were implementing the process. Before we dive in today and give you all opportunities to start practicing this work, we wanted to share an optional tool that you can use to guide your brainstorming. So in a second, Maria will drop a link into the chat of a worksheet that, again, is a completely optional tool for you to use to record your thoughts during this session. So feel free, once you have the link to the worksheet, to make a copy that's editable by going to File, Make Copy. I know some of you might have printed out this worksheet in advance, so if so, now is a good time to pull that out. And please, if you're having any trouble accessing the worksheet, do let us know in the chat and Maria will monitor that. All right, let's dive into the process. So the first step of the process is to build consensus and understanding on clearly articulated outcome goals with your partners. And Maria mentioned outcome goals earlier, and some of you may have been thinking, what does that actually mean? What does that piece of language mean? So we've provided some examples on the slide of what we consider outcome goals. An outcome goal might be increasing stable housing. It might be eliminating racial disparities and retention rates. It's really an outcome that folks in services are working towards, and that directionality of increase, eliminate, reduce, decrease provides the goal component. Regardless of what your outcome goals are, they should really drive each step of the process of using data to guide decision-making and advance equity. And because these outcome goals are driving the process, it's important for all partners to be working on shared outcome goals together. And this is so that when it comes time to make changes, everyone feels really aligned and bought in on the why behind any revisions. We've kept the word partners broad here for a reason. These could be behavioral health agencies, peer specialists, housing providers, schools, courts, hospitals. The list can really go on, but really these are folks who are also interacting with the people that you are serving. We recognize that there might be many different outcomes goals that you're working towards and that feel important. So the question then becomes, how do you prioritize? How do you decide with your partners what to focus on right now? So we've seen 3 criteria come in handy for taking a large list of outcome goals and narrowing that down. The first is importance and need for improvement of the outcome. So does something like housing stability need improvement in your community? The second is ability to impact the outcome. So can the services actually move the needle on that outcome? And the third is measurability, whether you're able to collect and access data on that outcome. So on the slide, we've formed these 3 criteria as questions. These are questions that we encourage our partners and the folks we work with to ask themselves and their partners to assess whether an outcome meets the criteria. And we recognize that there may be trade-offs here. Some outcomes may need a lot of improvement. So you might answer yes to this first question. Some may only be, that same outcome may only be somewhat able to be impacted. And it may be really difficult to collect and access data on. So we encourage folks to have conversations with their partners about those trade-offs, what they are, what you can work towards. But we also encourage folks to start by focusing on outcomes that strongly or somewhat meet all 3 of the criteria on this slide. So before we give everyone some time to independently think, we want to poll the group on 3 different example outcomes to assess how they meet the criteria across your unique contexts. So I see Maria is open to the first poll. I'm going to give a few example outcomes, and hopefully you all will be able to enter responses into the poll for how the outcomes fit the criteria. So the first example outcome is increasing the number of Black, Indigenous, and people of color individuals enrolled in behavioral health programs. So I see responses starting to trickle in, but please respond to the poll and answer how that outcome aligns with the criteria introduced today. I'm seeing lots of folks feeling like this outcome is really relevant and important and can be impacted, and we'll share the results as we end the poll. Looks like this outcome is also pretty able to be measured by existing or new data. All right, well, we have about half responses. Maria, I think you can feel free to close this poll and launch the other one. I know we have 2 more outcomes to get to today too. Okay, the second outcome is decrease recidivism of people in behavioral health programs. So you know what to do. Start filling out the poll for how that outcome aligns with the 3 criteria. All right, I'm seeing some more mixed responses on this. I think a lot of folks are feeling like this is relevant and important and does need improvement. But there's some debate about whether in your communities this outcome can actually be impacted by services being delivered and whether it's able to be measured by existing or new data. All right, why don't we move on to our third outcome, Maria? Great. So the third outcome is increasing referrals to other behavioral health programs upon discharge from services. Looks like the majority of folks are responding, yes, this does meet the 3 criteria. We do have some no and somewhat responses, so I think there's a little bit more of a mix here than our first outcome example. Okay, well, I know we have a lot to get to today and want to give you some time to do some independent thinking. So thanks for closing that poll, Maria. Hopefully folks have a chance to scroll through the results and see what other folks said. Okay, well, now that we've assessed across the group how 3 example outcomes fit the 3 criteria we shared, take 1 minute to do some independent thinking and write down 1 outcome goal, either from the poll or a different outcome goal that you would like to work on in your community with your partners, and that fits the 3 criteria above. So we'll have about a minute for independent work, and feel free to use the worksheet or jot this down on another piece of paper. All right, well, I'd love to have a few folks, as you're wrapping up your thoughts and continuing to write down an outcome goal, would love to have a few folks just drop your outcome goal into the chat. I think it could be interesting for the group to see what some of the different outcome goals prioritized by folks were. So take a minute, finish up your thoughts, drop your outcome goal into the chat. And as you're doing that, I'm going to move on to sharing an example from California that really shows how consensus on outcome goals can be built not just within jurisdictions, but also across jurisdictions. So Third Sector has worked for more than 2 years with 8 county behavioral health agencies across California. And we've helped them develop shared outcome goals for a community-based outpatient program that's administered in all of the counties across the state for people with serious mental illness. And this program is really similar to the assertive community treatment model, which I know is used across the country. As you can see from the map here, these counties were rural and more urban, some were inland, others were coastal. But despite differences in community and in context, all of the counties were really bringing the goal of being able to better compare a set of standard outcomes across the state. And this was in order to facilitate sharing and uplifting of best practices, and also decisions about resources and where to invest them across the state. So we worked with the counties to undertake a really iterative and consensus-driven process in order to help them decide what's priority to focus this program on and to measure. And even though this process was led by county agencies, they took a really human-centered approach of prioritizing outcomes that felt relevant and important to both people using services and to frontline care staff. And in order to do this, third sector worked with the county agencies to facilitate focus groups and interviews with staff. And those included case managers, clinicians, co-occurring disorder specialists, peer specialists, and also with people using services and when it felt more appropriate with their caregivers. People of all races, ethnicities, genders, ages, mental health challenges were interviewed as part of this process. And this was really to ensure representation and input of the diversity that the counties know exists across and within counties, and to be able to parse out any nuances between groups. I should note here too that our team facilitating these interviews and focus groups was at the time majority white, and we did not always live in the communities that we were working in. So we actually partnered with organizations who were on the ground, who already knew and lived in and had trust with these communities, to help develop interview questions that were healing centered, facilitate interviews when appropriate, and also connect us to interpretation services so that folks could share their reflections in their preferred languages. People using services who participated in the interviews were also compensated with gift cards. And we really encourage doing this for any human-centered engagement because it can really help recognize the value of folks' time, contributions, and also the vulnerability that people are bringing a lot of times when they're sharing their experiences in mental and behavioral health services. So ultimately, these interviews and focus groups informed 4 outcome goals, and you can see them at the bottom of this slide here. And I want to specifically call out social connectedness because this was an outcome that had not been tracked across the counties consistently, but was uplifted in many interviews and focus groups by people of all races, genders, backgrounds, circumstances, as being really critical to people's recovery journeys. And so the counties actually decided to prioritize this outcome and edit a standard statewide form to include a metric that tracked social connectedness. So they really wanted this to be a focus of ongoing cross-county data reviews, discussions, in order to be able to help counties and providers design services that could increase social connectedness. All right, we just finished the first step, 1 down, 4 to go. Take a couple deep breaths, process some of the material that's been shared, and then I'll move on to the second step. Okay, and I see some outcome goals in the chat. I see increasing access to resources, improving services to move more clients towards graduation, decreasing the number of trans youth reporting symptoms of depression. Thank you all for sharing, and feel free to keep dropping those outcome goals into the chat as we move forward. Okay. So the second step is to use qualitative and quantitative data and metrics that will help you track progress on outcome goals. So if an outcome goal is increased stable housing, like I shared in step 1, a metric is that more specific data point that makes the outcome goal measurable. So one example of a metric could be the number of days that an individual is in stable housing over the previous 12-month period. Another metric could be the number of times each person experiences unstable housing. So again, same as with outcome goals, there are lots of options for metrics, as you can imagine. And we've shared a tool on here called data mapping that can help you organize and determine which metrics are feasible to track through data. So with data mapping, we suggest mapping out 5 categories that you can see on the slide. And we've included questions to ask yourself to help you guide mapping and filling out this data map for each metric. So I'll just quickly walk through an example to show how to apply this before we give you a chance to start doing a piece of the data map yourself. So if the outcome goal is to improve social connectedness, like it was for some of the counties in California, one metric could be the answer to a question: how often do you get the social and emotional support that you need? And this was actually the metric that the 8 counties across California chose to incorporate into their standard statewide form. In addition to collecting data on the metric, it is important to collect demographic information such as race, zip code, income level, and making sure demographic information is representative of your community and context. And this is so that in the next step, which we'll get to in a few minutes, you're able to identify any disparities in outcomes in these data on these metrics across groups of individuals served. You may already collect data on this metric in an existing form, but like the counties in California, you may also need to edit or add to an existing form. And we really encourage this whenever possible, not creating any new forms, because we know that reporting burden can be such a challenge. The access section of the map is also the place to note whether data would be collected on a paper form, in an electronic health record, or in another system. And this will really influence the timing piece of the data map, because if data is entered on paper, which works for some systems, it may need to be uploaded into an electronic health record or another data system before it's able to be accessed and analyzed in aggregate. It's also helpful to note here the frequency. So are you collecting this data once upon intake, every month, every 6 months, during an annual assessment? This will really impact how you use the data, so it is important to get specific here about frequency. The next two categories here of quality and ownership can sometimes be interlinked. So you may have data on a metric that's collected relatively consistently, and that may be influenced by the processes you have in place for collecting the data. So who is responsible for entering the data and collecting the data? Is it a self-reported measure? Is it collected during an appointment between a clinician and the person they're working with? Others might be a clinician assessment or an assessment by a case manager. So again, really important to talk about ownership here and who all the different players are in collecting these pieces of data. So hopefully this gives you just a little taste of how you can use the data mapping tool. And now we're going to give you some time to think about this in your context again. So we're going to give you space to practice filling in the first two sections of the data map here, metric and access. So take a couple minutes to write down 1 to 2 metrics that you could use to track progress on the outcome goal that you listed for step 1. And also write down whether this is currently collected or where you hypothesize data on this metric might be collected if it's not currently collected. All right, take another minute to finish up your thoughts, and then we'll dive back into an example.
To give voice to what I put into the chat. Also, metrics typically begin with something like the number of or the percent of, if that's a helpful start. And feel free to drop your metrics into the chat as well.
All right, well, we're going to keep moving on to an example, but feel free to keep finishing on up writing, and as Maria said, drop your metric into the chat and whether you're actually currently able to collect data on that metric. And I think it'd be great for folks to see whether some new data collection processes need to be in place for some of these metrics, or whether this is something that you all are already collecting data on currently. All right, so this next example is from Siskiyou County Behavioral Health Services. Siskiyou is a rural county in Northern California. So you may remember the map visual I showed during the first example. Siskiyou was that topmost county way up on the Oregon border. Demographically, Siskiyou is majority white. About 85% of county residents identify as white, 5% as Native American, 6% as 2 or more races, and then 13% as Hispanic or Latino. Geographically, Siskiyou is quite large and spread out, but population-wise, it's a pretty small county. There are about 44,000 people who live in the county. And that translates to the size of the outpatient program for people with serious mental illness as well. That program serves about 250 people annually, so it's quite small. And because the outpatient program serves a small number of people, the same staff for that program actually see folks in less intensive programs as well. And though the types of support and level of care is meant to differ between this outpatient program that serves people with serious mental illness and other programs with less intensive care, in practice, these programs and the level of care actually looked very similar. And this was compounded by the fact that there were no standard guidelines for care that had been written down for the outpatient program geared towards folks with serious mental illness. So the program director and staff actually hypothesized that this was contributing to what they saw was a lack of movement and progress through services. And I saw someone dropped in the chat an outcome goal around sort of moving more clients towards graduation. And this was something that Siskiyou was really interested in as well. So we worked with them to develop new service guidelines that embedded an evidence-based case management model called the strengths model, and to design a new definition of and indicators of recovery. So really to help staff understand the North Star that they were working towards with people in services. And we did this in partnership with clinical experts at the California Institute for Behavioral Health Solutions. So Siskiyou's goal is on the slide here. I just mentioned it. But one thing they did to support achievement of that goal was they created a new tiered structure of service delivery, where they had internal designations for folks as either tier 1 or tier 2, based on factors such as risk of hospitalization, how easy it was to engage people in services. And these internal designations were used to guide staff in making decisions about caseload, intensity of services, so the number of touch points people were receiving in a week or in a month, and care coordination, so who on the care team was actually being brought in on a regular basis. And feel free to note in the chat if you work with behavioral health services that have a tiered structure. I know that this can be common across contexts. So a metric that was used to assess progress on the outcome goal was the number of changes that folks made between tiers 1 and 2 in the previous 12 months. And Siskiyou actually explored incorporating these metrics and some of the tier assessment into their intake and into their annual assessment form, because they had really low data collection capacity and didn't want to add additional burden onto staff. But they decided not to do this ultimately because they wanted to be able to update the tiers as folks were progressing through services. And they didn't want to have to go back to forms that they had already filled out and make changes to that as well. So they developed a simple one-page form, which you can see on the left side of the slide, and was entered into their electronic health record. And again, recognizing that staff had really high caseloads and sort of low capacity to collect additional data, they took a human-centered process by bringing staff into the design of this form and really trying to introduce as many checkboxes and as much automation as possible to make the form easy for folks to fill out. This form is filled out at initial intake by a clinician, and then it's also filled out as necessary as folks are progressing through services by a case manager. And though the case manager is the person that's responsible for actually making changes to the form itself in the electronic health record, the case manager is required to bring in others. So bring in the supervisor, the clinicians, a psychiatrist or nurse practitioner, any other care team members into the process of changing the tier form during new case conferences and multidisciplinary team meetings. And this was to create some of the shared accountability for tier changes. So Siskiyou is using this form to assess movement at the individual person-centered level, but they're also using it to assess patterns across all people and services. So you can see we called out here that they collected demographics to be able to assess whether there were any disparities in tier movement by race, ethnicity, gender, and age. So I just shared how Siskiyou brought a human-centered racial equity mindset to collecting new data on their outcome goal. So now we'll talk about, once you have that data, what do you actually do with the data? And this is the next step, step 3. So in this step, you are working with your partners to capture insights for deeper conversation with other stakeholders. And again, this is another step that's helpful to do with your partners, because folks may want to ask different questions of the data, and this will ultimately guide how the data is sliced and diced. So to share an example, if your outcome goal is to improve housing stability, and the metric is the number of days in stable housing in the previous 12 months, one partner might be interested in the average number of days in stable housing across all people and services. If you're working with the probation department or a diversion program, they may be really interested to see whether there's a correlation between the average number of days in stable housing and the number of times folks are incarcerated or recidivate. And they may also want to understand whether this differs by zip code or by race or ethnicity or age. So all these questions are really helpful to guide how the data is broken down to assess patterns. And when you're breaking down data and doing an analysis, it's important to disaggregate by different demographic categories. And you can see some sample categories here on the left side of the slide. And this is because we know improved outcomes in aggregate can actually hide disparities that are not improving or that are worsening. So as I mentioned, we've included some sample categories for disaggregation here, but this list is not exhaustive. There are many more. And the categories you choose should really depend on your and your partner's goals and on your community and context. So once you've analyzed the data, it's important to first note insights before drawing any inferences with partners. So before unpacking what you're seeing in the data, it's important to just highlight some of the patterns or trends you want to dig into further in step 4 with your partners. We've also listed some potential data insights to note on the right side of this slide. So if you're seeing differences across providers or across regions in your data, that might be something to highlight and come back to with your partners. So now we're going to give you some time to independently think again. Take 2 to 3 minutes to write down 1 to 2 analysis questions that you would be interested in exploring for each metric that you would like to collect data on in step 2. And as a reminder, an analysis question might be something like, what is the average number of days in stable housing across all people and services? Or am I seeing disparities by race in the number of folks that are recidivating in behavioral health services? So take a couple minutes just to write down some analyses questions. And as you're writing, feel free to drop any thoughts you have into the chat. All right, take another minute or so to wrap up thoughts. Okay, I'm going to move to sharing an example, but again, feel free to finish up whatever you're writing down. And if you have an analysis question, please add it to the chat. Okay. So this next example comes from the Los Angeles County Department of Mental Health. And this is the largest county operated mental health agency in the country. They serve more than 250,000 residents annually. So very different in size and scale from the Siskiyou example. Demographically, Los Angeles County is also different than Siskiyou County. A majority of residents identify as Hispanic or Latino, 49%. 26% identify as white, 15% is Asian, and 9% is Black. And as I mentioned, the scale is very, very different from Siskiyou. So the outpatient program for folks with serious mental illness is about 80 times larger than Siskiyou's. They serve approximately 20,000 people annually. Like Siskiyou, though, the outpatient program does include wraparound supports. So they have housing, case management, employment services, the types of supports that I imagine you all may be really familiar with and might be implementing in your communities as well. And unlike Siskiyou, because the program was so large, the county agency actually contracted with providers to deliver these services. And the county realized that their existing model for provider contracts made it financially unsustainable for providers to deliver the kinds of wraparound supports that they knew were really effective for people with serious mental illness. So as Maria mentioned in her introduction, we actually worked for about 3 years with the Los Angeles County Department of Mental Health and with their providers to launch the largest system of outcomes-focused mental health service provider contracts in the country. And this covered over 190 clinics. And we did this in partnership with the University of California, Los Angeles. And again, this was really to, as Maria mentioned, have folks put their money where their mouth was and have the county do this. And this was to incentivize the mantra of the outpatient program, which was to do whatever it takes to help people. So one piece of this contract redesign was incentivizing the achievement of specific outcomes and tracking new metrics to be able to capture progress on those outcomes. And some of these metrics were attached to payments in the contracts. Others were merely used to look at for ongoing learning and improvement. And as you can see on the slide here, the county and the providers were really curious to learn more about how services were being delivered to children and youth in the county. And you can see on the left side of the slide some of the specific metrics that the county tracked. And these were in order to really gain a better understanding of which children and youth were being referred, enrolled, and then actually kept in services and engaged on an ongoing basis. On the left side of the slide, you'll see that these metrics were disaggregated by different categories. Race and ethnicity was one category, really in order to understand any disparities by race and to be able to make movement towards racial equity. But also were included as disaggregation categories, high priority groups of children and youth that had historically poorer outcomes, such as children and youth who were removed or were at risk of removal from their homes by the Department of Child and Family Services. So this is an example of how to actually take the principles of disaggregation and customize that to your specific outcome goals and your own context. All right, we're halfway done with the data for equity process. So again, take a couple deep breaths, take a second to digest, and then we'll move on to step 4. All right. So the 4th step is, now that you've noted things such as differences by race or zip code, the next step is to get together with your partners and ask, what does this mean? What is driving what I'm actually seeing in the data? And sharing the data with your partners is a necessary precursor for then being able to collaborate on it. And we've seen digestible visuals that include disaggregation and allow for some quick identification of differences among groups as being really helpful. And when I say visuals, this doesn't have to be a more built out dashboard. I know it can be challenging to have capacity to create something like that. So we've also seen simple charts and tables be really effective as a starting point there as well. The data that's shared should also be data that all partners want. And this is so that once you're engaging in some of the collaborative discussions around what the data means, everyone is feeling really bought into and interested in having some of those conversations. We recommend these discussions happen frequently, at least quarterly. And this is so that you're really able to respond to what you're seeing in the data while it's still relevant in real time. And we know it can be helpful to leverage existing spaces too, because folks have a lot of meetings and are really busy. So if you are trying to increase the frequency of these conversations around data, it can be helpful to try to embed them into existing meetings and to include both celebrations of successes and time and space to develop a shared understanding of how the data is being analyzed. So how are you making certain calculations, and the whys or the root causes behind any patterns or trends that you're seeing, really in order to approach the data from a place of curiosity and with a learning mindset. So to do this, we typically use a tool called root cause analysis. I recognize that some of you may be familiar with this. Some of you may have done a root cause analysis before. But to make sure we're all on the same page about what root cause analysis means and can look like, we'll now practice doing one together. Root cause analysis is the process of working with your partners to unpack a specific data point or trend by asking why at least 5 times to get down to the roots underlying what you're seeing in the data. And this is actually a relatively simple process that just means asking a question in a repeated way, but can yield some really interesting and new insights from what we've seen with our partners and in our work. And this process is the first step towards developing revisions to systems and services in step 5 of the data for equity process. And this helps ensure that when you do design those revisions, you're solving for underlying root causes, not just root causes at the surface level. So now we're going to try practicing this together, and I'm going to request that you all are active in the chat. And the data trend that we will use as our example today is on the screen here. So what I'm going to do is I will ask the group why questions, and folks should drop answers to their questions in the chat. This can and should feel like a really rapid fire brainstorm together. So please now drop into the chat some reasons why you think in a hypothetical example, you might be seeing an average time from referral to first kept appointment as 30 days for a child outpatient program in a totally hypothetical county. Great, I'm seeing one route is not enough providers. Other ideas that folks have? Missed appointments, difficult schedules. Yeah, these are all great ones. Transportation challenges. I know that this can particularly be an issue or a challenge in rural areas. So appreciate folks bringing that in. Well, keep dropping in those routes. I think that one, which we've gotten at in the chat from the staffing and scheduling perspective, is folks may not have any available appointment slots. So if this is one of the routes, no available appointment slots, curious for folks to drop into the chat reasons why there might not be available appointment slots. Why might you be seeing this? Yes, high caseloads, not enough staff. So I'm seeing some staffing challenges. Other reasons or roots? Yes, there might just be a lot of need. I'm seeing some more reasons around sort of hours and schedules and operations. I think another example, which I'll bring in, is that folks, might be ready to leave a program, but might be being kept in services for some reason. And that kind of gets at the root of there's a high volume of people needing services, and some slots might be taken up. So now I'd ask folks, why might people who are ready to step down or leave a program be being kept in a program? What are some roots of that? I'm seeing lack of available services, providers not noticing signs of someone being ready to step down or graduate, nowhere to send them. Yep, I think we've seen that a lot in California, is that can be really challenging to step folks down when there are no other good options in the community. And I think that ties to Virginia's response about money, not having the resources. An example I'd highlight too from our work in California that we've seen in some of the counties is that the provider may not know which other programs in the community have capacity. So why might the provider not know which other programs have capacity? Too busy? Yep. We know folks have really high caseloads, and often it can be hard to think about care coordination with outside agencies. Silos. Other thoughts from folks on potential roots behind this lack of knowledge about which programs have capacity? Yeah, lack of systems to communicate, changing availability. These are great ones. Thank you all. And I think you all got at this, but lack of coordination is a huge challenge that we see across jurisdictions, and one that we try and tackle with our partners. So this is our last why question in the 5 whys, but why might there be lack of coordination across programs and an agency that contracts with providers? I see lack of communication, insurance differences, competition. Yeah. Well, agreed, Gail, that lack of communication can be a huge challenge. And that's one, actually, some of our clients, which I will share in a minute, really wanted to work towards. So thank you all for participating in this really collaborative rapid fire brainstorm. I hope this gave you a little bit of a taste of what root cause analysis can be like. This is really just one branch of a larger root cause analysis tree. So as you can see from all of the other great responses that folks dropped into the chat, there might be many other top line roots besides this no available appointment slots route. And you can actually build out some of those top line roots to form more branches. So this root cause analysis, when it's done holistically, should really look more like a root cause tree. So after the 5 whys, we do recognize that it can feel really challenging or impossible to tackle all of these roots and to develop revisions to systems and services for all of these. So we actually encourage folks to work to prioritize roots with partners. And we do encourage trying to address deeper roots. And this is so you're not investing time and resources into areas that will not make the greatest impact. And as you saw, again, folks brought in some really different roots in the chat. And I think this really underscores the importance of doing this in partnership, because people are bringing different perspectives, experiences, and ideas to the table. So one example I will share here is a county agency that has been applying root cause analysis collaboratively. And this is the Fresno Department of Behavioral Health in California. Fresno is a mix of rural areas and urban seats. Fresno City is an urban area in the county. And Fresno is majority Hispanic or Latino. So about 54% of county residents identify as Hispanic or Latino. 29% is white and 11% is Asian. Size-wise, their outpatient program for folks with serious mental illness is somewhere in between Siskiyou and LA County. They serve about 1,600 people annually, and their services are delivered by 7 contracted providers. And while the department and the providers had regular conversations about contract requirements, they had many fewer conversations about outcomes and data. And both the providers and the agency staff were really interested in creating spaces for these conversations and space to build trust and shared accountability for making system and service improvements. So we worked with the county to help them develop a process for collaborating on data together. And this new process included designing new interactive dashboards that providers could access in real time and filter by things like race and zip code. And the county and providers made sure to include filters that were really specific to the communities. So Fresno serves a large Hmong population, and this was one of the ethnicity categories included in the filters. This new process also included redesigning existing one-on-one spaces between the county agency and providers in order to discuss provider-specific data trends. And it included developing new space for discussions across all of the providers on county-wide trends. And these all provider meetings included sharing of best practices, space to ask the agency questions, time to brainstorm revisions together. And you can see on the left side of the slide here, just one small piece of a root cause analysis conducted during a recent meeting on the same timeliness trend that we just practiced our root cause analysis on. So they really wanted to be able to approach data in this space with a learning mindset together. And this was the first time the department and the providers were coming together to discuss data on a regular basis. So they recognized there might be some trial and error there, but already just in their first meeting, creating this space together resulted in an immediate action. And the agency was actually able to connect hospitals to the care providers to facilitate more discussions on referrals. All right, on to the last final step for today. This is a culmination of the rest of the process. So after you set shared outcome goals, collected data to track progress on those goals, unpacked that data with your partners, done some analysis and disaggregation, this next step is using what's been learned to develop revisions to systems and services with your partners. And we suggest using a how might we question to frame any of your brainstorming. So an example of a how might we question could be, how might we decrease the time between referral and intake? Or how might we improve stability of housing in our community? And once you have that how might we question that can be used to guide brainstorming, we do recommend incorporating different types of brainstorming into your discussions. And this is because people think really differently, and new ideas might arise from reverse brainstorming versus opposite thinking. And we're happy to delve into what those different types of brainstorming look like during our diversity talk in June. So once ideas are generated, prioritization is key. Similar to the outcomes prioritization in step 1, it can be really helpful to develop shared criteria that will help you narrow that universe of improvement ideas. And as you're brainstorming, narrowing ideas, developing plans to implement, we do encourage you to live out that human-centered value by seeking input from people directly impacted by revisions, and even involving them in design. I know this can feel challenging sometimes, and what we've seen is when it does feel challenging to involve people using services so closely in design, we've seen folks work with peer staff as folks who have lived experience, but also work as providers. When gathering input, important again to consider the population that you're working with, really to ensure that the input you're gathering is representative of the community you're working with and also of voices not often heard. And we encourage compensating for input to make changes more valuable and relevant to those who are the end users. All right, so I'm going to give you the final opportunity to practice this process. So please take a couple minutes to write down 1 to 2 ways that in the future you might work to address root causes with your partners. And these don't need to be improvement ideas. These could be things like creating space for conversations with your partners or sending over a piece of data that you've had questions about and wanted to dig into. So no need to have ideas right now on improvements made, but take a couple minutes to brainstorm how you might get the conversation started. Take another minute to wrap up any thoughts. As you're working, feel free to drop any ideas you have into the chat. Okay, so I'm going to move on to our last example for today, which comes not from California, but from Washington State. This is King County in Washington. It's the largest county in the state and the 13th largest in the US. And demographically, the county is 59% white, 20% Asian, 10% Hispanic or Latino, and 7% Black. And it's a pretty large county. About 50,000 people receive outpatient mental health or substance use services each year. So the county really wanted to improve rapid access to outpatient care and follow-up. So very similarly to LA County Department of Mental Health, we worked with King County to embed performance incentives in the form of bonus payments tied to timeliness metrics into existing contracts that the county had with 23 providers. As you can see on the left side of the slide, the county sends providers a monthly update on the data, really to facilitate improvements to those timeliness metrics, and coordinates a monthly learning community for providers to be able to learn from each other and develop program changes together. And with the recognition that changes can take time and resources, the county wanted some of that burden and accountability of changes to be shared. So they gave opportunities for providers to get funding to make revisions to systems and services that were designed both during and outside of the learning community spaces. And all of this ultimately led to a 50% reduction in wait times between initial contact and intake, and also has served as a model for the county shift in Medicaid towards value-based purchasing. All right, well, thank you all for the engagement, the participation in the chat. We do recognize we just threw a lot of material at you and we didn't have time to dig deeply into the steps, any potential roadblocks that might come up during the steps and how you can address and kind of mitigate some of those proactively. And we also know that you all might have some really sticky questions on some of these steps. So now I'm going to turn it over to Maria to talk briefly about how we can answer some of those questions that you might have and how we can dig in deeper with you.
So first thing we want to know is what resonated. Did anything resonate? Please, as a last chat request, drop into the Zoom if what you can commit to taking back to your own context, even if, as Emma mentioned, it's just a commitment to open up the door on conversations with providers, or have a second look at your metrics, or to compensate providers or program participants when engaging them on feedback. Anything that you feel is directly applicable and implementable. We also recognize these are bigger system change efforts a lot of time, and would love to have a follow-up conversation with you, either at the diversity talk on June 14th, which we have already shared the link to register for once, and maybe Ingrid and Maria, we could share it again. Hope to see many folks there where we will not be bringing a presentation, and instead just structuring the conversation around the questions that we hear from participants and we hear in the follow-up survey. We would also love to have a one-on-one follow-up with each of you to explore your individual context and how some of these principles could be applied, and be a thought partner to you as you think through some of these. So if you are open to a one-on-one follow-up conversation with third sector, please add your email to the chat now, and we will follow up with you offline. We mentioned that there will be an evaluation sent out by MHTTS, which will include a question on some of the things you may want to raise in the diversity talk. So we really hope to see you all there or in separate conversations. Feel free to add Emma and me also to LinkedIn, and we will drop our emails into the chat as well in case you want to reach out. So appreciate everyone's time, and turning it back over to Ingrid, Maria, Dr. Wyatt, and the MHTTC.
Thank you so much. This was a great presentation and really an engagement to really think about how to use data effectively when we're thinking about advancing health equity. And so we are so appreciative to Maria and Emma for their time today. Again, we will have a follow-up to this learning conversation on June 14th at 1 p.m. in which we can really kind of dig into some of the specifics on how do we do this work. I think today's reminder was really understanding that this is a process. We really have to be reminded of our whys and encouraged throughout the process, because it often takes a lot of time to understand data and to implement its findings in a way that is most helpful to the people that we serve. And so I am excited about the follow-up conversation on June 14th as we begin to operationalize some of the steps and concepts and really the framework that was provided today. Again, just as a reminder, our funding comes from SAMHSA, and because of that, we will be sending out a survey to give some feedback about today's session. The link to that survey was popped in the chat already, but we'll also follow up by sending you the survey via email. If you are interested in more information about MHTTC or the REACH learning community, please email myself or Maria at the emails that are on the next slide. And we are more than happy to connect with you and really do some of this work in your own organizations. If you're in the New England area, we're more than happy to be of service in that way. Thank you so much to our presenters. Thank you so much for our participants for joining us this afternoon, and we will see you on June 14th.
Thank you all. Thanks for joining.